Good afternoon, good morning, and good evening from wherever you are joining us today. Welcome to today's webinar highlighting the 30th anniversary of the Black Women's Health Study. My name is Yvette Cozier. I'm one of the leaders of the BWHS, and this webinar will last approximately an hour. If you have any questions during the presentation, please click the Q&A button at the bottom of your screen. And if you have any technical problems, please click the chat button and let us know, and we will try to help you troubleshoot. Okay, so let's begin. So just to also note that we will have time for question and answer from the audience. Again, please use the Q&A button, and we will try to get to as many questions today as we can. So for today's presentation, I'm going to be joined by my colleagues, Dr. Kim Bertrand, Dr. Etienne Holder, and Dr. Lisa Barnes. And as I mentioned, we will have time for Q&A. We will talk about some of the future directions with the study and then wrap up. I first want to acknowledge the BWHS leadership. Joining me on this team is Dr. Julie Palmer and also Dr. Kim Bertrand. And to shout out our amazing advisory board made up of clinicians, researchers, just a fabulous group of women who have dedicated their work to women's health and Black women's health in general, in particular, I'd say. So before we move on to study results, and we will be sharing some of those, I just wanted to give a brief overview of the history of our study. Certainly, it's been a minute since you've all joined, and a little refresher is always good. So in 1995, when we began, 59,000 of you completed a postal questionnaire. Now, this postal questionnaire was not for the faint of heart. It was 12 pages, had really detailed sections, diet in particular. It came without warning, but you completed this. Most of you were subscribers to Essence Magazine. Some of you were also members of professional organizations like the National Black Teachers and the National Black Nurses Associations. And others of you were family and friends of individuals who received that first questionnaire and nominated you, or maybe passed the questionnaire on to you directly. But that's how you became enrolled in this study. Back then, our youngest participants were 21 and our oldest were 69. The median or middle age was about 38 years old. And for every 2 years, since 1995, we have updated your information through either another postal questionnaire or even online questionnaires. You are an amazing group. 75% of you have completed at least 10 questionnaires over this span of time. So including that first questionnaire in 1995, we've had about 15 questionnaires that we've mailed out. And so that 3/4 of you have filled out most of those. We are very grateful. So today, in 2026, we're a little more mature. I won't say older, we're just more mature. Right? Our youngest participants are 52. We have centenarians in our midst, with at least 11 of them turning 100 this year. Our active participants are down to 46,000 women. And I just want to take a moment to acknowledge that in the decades since we began together, we have lost the number of our participants. Many of our sisters have passed away, but they left us with an incredible legacy, and we are forever grateful to their contribution while they were with us. So the Black Women's Health Study is truly a national study, and our participants represent all regions of the United States. We also are a fairly international study now in that our participants are located across the globe, mostly within the Caribbean and Central America, and certainly on other continents, including Africa, Asia, and Europe. So as I noted in just a couple of slides previously, questionnaires are the main way that you share your information with us. These questionnaires are available both online and through the Postal Service. And the main themes of the data that we tend to collect, include body size measurements, lifestyle factors, so a diet, sleep, what we eat and drink, our physical health, including reproductive history and our medication use. And as early as 1997, our first follow-up questionnaire, we began asking questions about stress, particularly around experiences of racism and other types of stress and trauma that we explore in our daily lives. And we have published many times on the really bad, deleterious effects, the bad effects of racism on our health. And some of that we will talk about today. As other hypotheses emerge or we learn about other areas and basically how our cohort is changing in its characteristics, we have moved into other areas, environmental exposures, oral health, and as you'll hear later on during this presentation, around memory and cognition as we all get older. We've also asked lots of questions about diet. So here we've included a dietary assessment on 4 of our follow-up questionnaires. If you recall, these were some very detailed questions, wanting to know how often, the serving size, trying to get at exactly what it is that you're consuming and the ways that we can link or look at how what we eat, how that affects our health. But because these questions are so detailed, they're way too much to put on every questionnaire. Therefore, we put them on occasional questionnaires. We also collect additional information to help contextualize the data that you share with us. So for example, information from the Census Bureau helps us to understand the communities where we all live and work, and the environment, how we interact with our environment. Information from the Environmental Protection Agency, for example, can help us understand the things that we breathe, the things that we are exposed to every day. So these are ways that we enhance the data that has been that you have so graciously shared with us. I'm not sure how many realize, but the Black Women's Health Study is primarily funded through the National Cancer Institute, which is part of the National Institutes of Health. So cancer is one of the main outcomes that we study. However, we also study a number of non-cancer conditions. These are conditions that occur by themselves or can co-occur with cancer. Over the years, you may have been invited to take part in some of the sub-studies related to these conditions, both cancer and non-cancer. So regarding the sub-studies, over the past several years, in order to get additional information around a particular condition, we can't put a lot of questions on the questionnaire simply because of size and focus, but we may come back to you afterwards and ask for you to complete a second questionnaire or a supplemental questionnaire. We might also ask you whether you'd be willing to provide a biological sample. So we've collected mouthwash samples from women. We've also collected blood from women. At one point, we even invited women who were local to us here at Boston University to come in and have a dental exam so we could understand oral health a little bit better. So we thank you for participating in these many studies over the years. And at present, we have some new studies. including the cognitive health assessment, the environmental health study, and lung cancer screening. So you will hear about these studies in a few slides from now, I should say. And then this brings us to the 2026 questionnaire. I want to say this early, and I'm going to say this again, that your information remains vital to us. You have done such a wonderful job in sharing your information. Our next questionnaire will be available in just a few weeks, in June of this year, when our web version is available. Many of you enjoy filling it out online. If you don't get extra mail in your mailbox, in your physical mailbox, but this will be available in June. If we have your email information, we will send you the link for that. If we don't have that, at the end of this presentation, I will show you how and where you can update that information with us. If you prefer to fill out a paper questionnaire, that will be mailed at the end of the summer, beginning of the fall. And so around August or September, you should receive the paper version. The themes of this questionnaire, much like those of past, will involve, again, lifestyle, questions about preventive health, whether you engage in screening, you take vaccines, or you receive your vaccines. Again, your medical history and medication use, sleep quality, aging, and also, again, access to medical care and trust in the healthcare system. Many of these themes have been brought to us by you. So we thank you for sharing your ideas. We thank you for emailing us, for writing us, and telling us the things that you would like to be seen, researched, and addressed in our study. So at this time, I'd like to turn us over to my colleague, Dr. Kim Bertrand, who will talk about some of the recent findings from the Black Women's Health Study. Dr. Bertrand?
Hello. Hi, everyone. Can you hear me now?
Yes.
Pardon. Okay, thank you so much, Dr. Cozier. I'm excited to share just some of our recent project findings that we thought might be of interest to you. This is just a snapshot of all the research that the faculty here have been working on. Recently we developed a new breast cancer risk prediction model. And I want to just tell you what these are. So breast cancer risk prediction models are used clinically to predict women's risk of developing breast cancer, mainly to help guide decisions about cancer screening between individuals and their doctors. But the models that are commonly used in the clinic today were largely based on data from white women and tend to not perform as well in Black women, meaning that they basically underperform in Black women who are more likely, as many of you know, to be diagnosed at younger ages and with more aggressive forms of breast cancer. So it was really important to develop a new model that's really based on data from Black women. And the Black Women's Health Study team did come up with a new model, and they were able to show that this model was significantly improved over existing models and were particularly useful in younger women. And so that they perform really better than the previous models. This model is available on our website. I'm sorry I didn't include the link there, but you can definitely look at it. And we also showed recently that there may be even more benefits when you add data on genetic risk as well. And the other thing is recent advances in artificial intelligence have resulted in different types of models. So instead of being based on individual risk factor information like family history or reproductive experiences, these models are really based on just mammogram images, so the X-rays that women get when they get a mammogram. And new data suggests that some of these models might even perform better than the questionnaire-based models. But there's really little data so far in Black women and whether these AI models might work as well in Black women. So we've undertaken a new study using mammograms from more than 10,000 of you who agreed to share your mammograms with us, and looking at validating these models in future work. The Black Women's Health Study has also played a role in in reviewing and updating lung cancer screening guidelines. So you may know that there are significant racial disparities in lung cancer screening eligibility. So just as a reminder, low dose CT screening is underused just across the board in all racial and minority groups. But it's fairly easy and effective at early detection of lung cancer, which could reduce mortality rates by 20% or more. And these types of screenings are fully covered by Medicare and most state Medicaid and private insurance plans for individuals who meet the criteria. The problem is that compared to white women who have a history of smoking, Black women are much less likely to meet the eligibility criteria. And this is mainly because fewer Black women who smoke have a 20 or more pack year history of smoking. So pack years is just really the equivalent of smoking 1 pack of cigarettes per day for 1 year. So if you have smoked 20 pack years, that's 1 pack per day for 20 years. And so that's kind of the main eligibility criteria that have traditionally been used to determine who should be eligible to get lung cancer screening through these low dose CTs. And the other piece of it is women the 20 plus year pack year of smoking history applies to women who currently smoke or women who quit within the past 15 years. But I mentioned that Black women are less likely to sort of meet these criteria. And in the Black Women's Health Study, among women who had lung cancer, only 43% of them would have been eligible under the 2021 USPSTF guidelines for lung cancer screening. And so our colleagues here at the Black Women's Health Study and elsewhere performed a study within the Black Women's Health Study to sort of see what would happen if these guidelines were relaxed a little bit. So instead of requiring 20 or more pack years of smoking, what if we just take out the quantity of smoking and just have a criteria that is a 20 years duration of smoking? And when these criteria were applied, now 64% of women with lung cancer would have been eligible for screening. And these findings actually led to changes in the guidelines. So just a couple of years ago, the National Comprehensive Cancer Network released new guidelines dropping this requirement for pack years of smoking. They also dropped the restriction on time since quitting smoking. So these are really, actionable results from the Black Women's Health Study that have led to changes in policy. So that's pretty important. So we thank you for all your participation there. We also want to really understand the unique exposures that Black women face. So Dr. Cozier mentioned racism and socioeconomic status. So there's a great deal of evidence that where you live matters for your health. And Black women of all income levels are more likely to live in economically disadvantaged neighborhoods and more polluted neighborhoods compared to white women. And of course, this is in part and majorly due to the history of redlining and racial segregation in the United States. But we know that living in less advantaged neighborhoods can increase risk of several diseases. And among never smokers in the Black Women's Health Study, we did see that women who lived in these more disadvantaged neighborhoods had higher risks of lung cancer, even after adjustment for individual level markers of socioeconomic status and smoking history. So we've seen similar associations for other types. You'll hear a little bit more about breast cancer later on with Dr. Holder. And we've also seen it with multiple myeloma and other non-cancer outcomes as well, suggesting that contextual factors within neighborhoods are really critical to understanding disease risk. So with respect to experiences of racism, we've asked you on several questionnaires to let us know, how do you experience racism in your job, in housing, and with the police? And, maybe not surprising, even though race is a social a social variable. It's not really a biological variable. The physiological effects of racism are real and biological. And so what we've seen is that women who report more experiences of racism in these domains had higher risk of diabetes, coronary heart disease, and stroke. And we further showed that these factors, such as neighborhood disadvantage and experiences of racism, may also affect memory and dementia, like Alzheimer's disease. And so, experiences of racism were associated with worse cognitive function. Neighborhood disadvantage is associated with increased risk of Alzheimer's disease and related dementias. So these research findings really highlight the critical importance of understanding the social determinants of health and how these might influence disease risk. And pointing also to the opportunities for disease risk reduction with respect to, for example, community reinvestment, which may offer an opportunity to reduce the increasing burden of disease among Black women. And then something that I think has been of interest to a lot of participants is the exposures related to chemical hair relaxers. So we know that Black women are disproportionately exposed to harmful chemicals, not only in their environments, but also in personal care products. So chemical hair relaxers are heavily marketed to and commonly used by Black women to straighten their naturally curly or textured hair. And of course, this is in part to conform to Eurocentric beauty standards, but also maybe used by women just to manage their hair on a daily basis. But these products are poorly regulated and really already known to contain thousands of potentially toxic ingredients, including known carcinogens and chemicals that may disrupt estrogen and other endocrine disruptors. So in the Black Women's Health Study, over many, many years, we've been investigating the health effects of exposure to chemical hair relaxers. And we've so far seen associations for women who had long-term use of chemical hair relaxers had higher chances of developing uterine fibroids, higher risk of estrogen receptor positive breast cancer, and more recently, a higher risk of uterine cancer. And these findings are supported by findings on other studies as well. And I think really you may have seen on the most recent questionnaire, we've asked now more about chemical hair relaxers. And I think the next step would be to look at whether stopping use of these may improve health effects. Okay, so I'm going to turn it over to Dr. Etienne Holder, who's going to tell you a little bit about the new or current environmental health research that is going on within the Black Women's Health Study.
Thank you, Dr. Bertrand. Hello, everyone. All right, just want to make sure I'm pinned so you can see me as I'm talking. I'm new to the Black Women's Health Study, so I'd like to take a moment just to introduce myself. Oh.
Yes, I want to try to share again.
Hi, everyone.
Yeah. So
sorry about that. Zoom kicked me out, but that's all right. Not gonna let Zoom stop us from being great today. One moment.
And I just want to take a moment to thank the participants who are putting their questions into the Q&A. Thank you.
All right, how am I looking now, Yvette? All right, thank you, Dr. Cozier. Thank you, everyone. Thank you for your patience with my little technical hiccup. So as I was mentioning, I'm relatively new to the Black Women's Health Study, so I just wanted to take a moment to introduce myself. My name is Etienne Holder, and I'm a postdoc with the Black Women's Health Study. And I started close to 4 years ago now, it'll be 4 years in July. And I remember when I first started, I was eager to get involved, and I actually helped facilitate the webinar at that time. So I'm very excited to be here today to share some of my own research that I've had the privilege to conduct in the Black Women's Health Study. So thank you all for your contributions and for participating over these past 30, almost 31 years. So today I want to talk a little bit about the socio-environmental influences on health and some of my work, which focuses on breast cancer. And so my research, I'm really hoping to improve the health of Black women, and in part by reducing breast cancer health disparities. So to set the stage, let's take a look at the current breast cancer health disparities statistics. And so here we're looking at a graph that depicts the rates of new breast cancer diagnoses, indicated by the blue bars, and breast cancer mortality rates, indicated by the red bars, among Black and white women. And as has been well documented, and as we know, Black women are less likely to be diagnosed with breast cancer as compared to white women. However, when we look at mortality, the story changes. We see that overall, there's a 40% difference in the mortality rate between Black women and white women who have breast cancer. And so we're seeing that Black women are diagnosed relatively less often than white women, but they're more likely to die from their breast cancer. And so that begs the question why, and that's part of my work, is hoping to hopefully understand what this difference entails, reduce the health disparity, and hopefully reduce the impact of breast cancer for all women. One thing that I'm interested in learning about further as it relates to breast cancer, but other health conditions in general, is our environment. So our environment is made up of several different things, including the community and social conditions in which we live. That can be income and financial stability, educational opportunities, or experiences with chronic stress, discrimination, and racism. It can also involve different pollutions and toxic exposures, such as pollutions in our air and our water environment, what we're exposed to with respect to industrial pollutants and traffic-related exposures, and chemical products and chemicals in consumer products, such as, the things we're putting on our body, our soaps, our lotions, our hair products, the chemicals in those products and how that can impact health. Additionally, our environment is our physical surroundings. It's our neighborhood. It's the housing quality and safety. It's our access to different green spaces and parks and access to healthy foods. And so some of my initial work with the Black Women's Health Study as a postdoc was to look into the neighborhood environment and see how that was related to breast cancer survival. So I'd like to share two studies from the Black Women's Health Study looking at neighborhood conditions and breast cancer. So here, this is my colleague, Dr. Barber. Dr. Barber and I conducted research within the Black Women's Health Study to investigate how neighborhood disadvantage, which is living in communities with fewer resources and opportunities that support good health, impact breast cancer. Dr. Barber looked at neighborhood disadvantage in relation to risk of developing or being diagnosed with breast cancer. And then I further looked at, among women with breast cancer, how neighborhood disadvantaged impact survival outcomes. And what we found was that living in disadvantaged neighborhoods was associated with an increased risk of ER-negative breast cancer. And ER-negative breast cancer is a more aggressive form of breast cancer, which Black women are more likely to be diagnosed with. And we also found that in my work, women with breast cancer who were living in areas of disadvantage were at a higher risk of passing away from their breast cancer as compared to women who lived in areas that had more resources and more opportunities to support health. So further, at the Black Women's Health Study, we're interested in going beyond our physical environment and thinking about the chemical exposures that Black women are uniquely exposed to. And that brings me to the study. It's a pilot study on environmental factors in the Black Women's Health Study. So here we're interested in how the environment affects our health. And to look further into this, we started a pilot study using wristbands. Some of you may remember receiving the silicone wristband in the mail. It's similar to my Activity Watch wristband. It can pick up some of those chemicals that we're exposed to on an everyday basis. And this will help us to understand how the environment influences health outcomes. This pictorial on the right just shows some of the environmental chemical compounds that are in air pollutants, personal care products, other products that the wristband has the ability to absorb. We can then take those wristbands and have them analyzed in a special lab where we can then understand the amounts of each of the chemicals and look at it in relation to certain health outcomes, or look at chemical profiles among women who have certain health conditions to see if they have different levels of the chemicals compared to women who may not have those health outcomes. So the wristbands can pick up different things such as VOCs or volatile organic contaminants, flame retardant contaminants, those contaminants again in the personal care products, so the lotions that we use or hair products we use, and pesticides, for example. And here is what our pilot study entailed. We had our navy blue wristbands, and participants wore them for a week. They also sent back a questionnaire. I'm happy to announce that we've completed our wristband collection. We had 4,014 women who participated in our wristband study. And as this is a pilot study, to date, we have 816 wristbands that have been sent to the lab to be analyzed. And so they're currently at the lab. They'll be analyzed and we'll be able to receive the data back and conduct some further studies using the wristbands, using the chemical findings from the wristbands in relation to different health outcomes. And so as part of my work, I'm always thinking ahead, and the Black Women's Health Study in general is always thinking ahead about what the public health impact is of our work. And I think there's some key informational findings, especially from the work looking at socio-environmental context in terms of public health impact for the future. I think one of those important public health impacts is policy changes, especially when we think about the chemicals that are allowed in our environment, as well as our personal care products. We want to be able to use products for our hair, for our skin, and not worry that the chemicals may be bad for our health. I think some of this research can lead to important disease prevention, reducing the health disparity, improving women's health, and most importantly, improving quality of life for Black women and survival outcomes after a diagnosis. I want to thank you all for your participation and your contributions to the Black Women's Health Study over the last 31 years, and for your attention during my presentation. I'd like to now pass it off to Dr. Lisa Barnes, who will be sharing more about the Cognitive Health Study within the Black Women's Health Study. Thank you.
Thank you, Dr. Holder. We just started. Can everybody see? Am I good?
Looks good.
Okay, great. Thank you. Okay, good afternoon or good evening, wherever you are in the world. I'm Lisa Barnes. I'm a neuropsychologist in Chicago and also new to the Black Women's Health Study. I am really happy to, on behalf of the Cognitive Health Sub-Study, present some background information on why we started this study and what's included in the study. So the sub-study is about cognitive health, but one important consequence of poor cognitive health is dementia. I know that we've all heard about dementia and may even have had people in our families with this terrible disease, but let's start with the general definition to all be on the same page. Dementia is the umbrella term used to describe a range of symptoms associated with cognitive impairment, including a chronic loss of memory, language, problem solving, and other thinking skills. And these losses have to be severe enough to interfere with daily functioning to be considered dementia. So dementia is the general term for loss of cognition, but there are several diseases under the umbrella that cause dementia. And as you can see, Alzheimer's disease is the most common cause of dementia, with about 50 to 75% of diagnosed cases being Alzheimer's. But you can also develop dementia from having strokes. We call that vascular dementia. You can even have multiple causes, which we call mixed dementia. So dementia is a growing health concern for our population. Today, 1 in 8 older Americans over the age of 65 are affected by Alzheimer's disease and other dementias at an annual cost of more than $200 billion. And with the projected population increases, especially in the oldest age groups, it's thought that around 13.5 million individuals in the US will have Alzheimer's by the year 2050, unless we can find a cure. So prevention is a public health priority. There are important disparities with Alzheimer's dementia. We know that women have a higher lifetime risk at both age 45 and 65, shown in the graph on the left. And if you look at the graph on the right, here, I don't know if you can see my cursor. This was data from a study of over 270,000 healthcare members in Northern California. And in that study, they had data on 6 different racial and ethnic groups. And what is shown is that African Americans, represented by the purple line, had the highest incidence of Alzheimer's dementia compared to all other racial and ethnic groups, a finding that has been replicated in other studies in other parts of the country. So, a growing body of evidence suggests that African Americans are 2 times as likely as white Americans to have Alzheimer's dementia or another dementia, but the reasons are not well understood. We know that cardiovascular diseases and lifestyle risk factors like high blood pressure, diabetes, and physical inactivity play a role in Alzheimer's. And these factors also tend to be more prevalent in African Americans. So, one hypothesis is that higher rates of cardiovascular disease in African Americans could be the reason for the higher risk of Alzheimer's. But is there another reason? Could there be another reason? We know from decades of public health research that most of our health is influenced by factors outside the walls of a hospital. In fact, up to 40% of our health is due to social and economic factors, more so than our genes, more so than clinical care, even more so than our own individual health behaviors. And as we've heard in earlier presentations, race is a social construct that's rooted in cultural identity and shaped by historic events. And we and others believe that the reason for the disparities, at least one of the reasons for the disparities in dementia, may be due to what we call social determinants of health. That is, the conditions in which people are born, grow, work, live, and age. And it may not be the conditions themselves, but rather the systematic and unjust distribution of these conditions. So the fact that the economic, social, and environmental conditions that are needed for health are not evenly distributed across populations could be the reason for the disparity. In other words, as we've heard in prior presentations, you have the haves and the have-nots, and that could be one of the reasons. So I'm in Chicago and I run studies in Chicago on older Black Americans. And in one of my studies, we have been measuring some of these social determinants. And in one study, we found that those older adults who reported attending legally desegregated schools in the South as children performed more poorly on our cognitive function tests when they were older, so in their 60s, 70s, and older, compared to other participants who attended legally segregated schools in the South and compared to participants who attended schools in the North. In another study, we found that African Americans who reported higher perceived stress, essentially that their lives were unpredictable, overwhelming, and uncontrollable, had faster rates of cognitive decline on our tests, so shown with the blue line, compared to those who reported less perceived stress, shown in the green line. And this was true whether we asked about, historic factors related to discrimination or even more contemporary stressors that people face today. Closer to home, data from the Black Women's Health Study was published in 2020 on the relationship of experiences of racism and subjective cognitive function. Subjective cognitive function is the perception of your thinking skills. So we might ask you to rate whether or not you think your memory is worse than it was 10 years ago. That study used questions from a structured telephone interview for dementia assessment and found that experiences of daily and institutional racism were associated with lower subjective cognitive function in over 17,000 Black women over the age of 55. And women who reported the highest levels of daily or institutional racism were estimated to have more than 2.5 times the risk of poor subjective cognitive function as women who reported the lowest levels. So I hope I've convinced you that there is a strong precedent and a need to understand how social determinants and early life stressors affect actual cognitive aging in Black women. So we wrote a grant to measure cognitive function in the Black Women's Health Study, and we're funded in 2024 by the National Institute on Aging. And this sub-study includes about 2,500 participants who were at least 55 years of age, had donated a blood sample and agreed to have it used for research, and also agreed to be tested over the phone once a year for up to 5 years. The study has 4 goals. Number 1, we will measure cognition with a brief battery of neuropsychological tests over the telephone. Number 2, we will measure brain proteins, what we call biomarkers, in stored blood and examine their relationship with cognition. Number 3, we will assess the relationship between stress measures that's been collected in the Black Women's Health Study since 1995 and relate that to cognition. And finally, we will determine the genetic profile of participants and combine the genetics with the biomarker data to see what might predict cognitive decline. There has been enthusiastic interest in the study, and we've already completed the first interview on 2,554 women, and we're currently completing the second interview, having completed more than 1,800 interviews to date. We expect to be done with the second interview before the end of the summer, and we'll be reaching out to schedule the third interview very soon. You can see we have a nice age distribution with most women being between 55 and 74 years of age, and a nice regional distribution across the country. So on behalf of the entire Cognitive Health Study team, I want to thank all of the women who are participating. We look forward to continuing our partnership with you and together learning what are the factors that affect Black women's cognition as we age. Thank you so much for your attention, and now we can turn to Q&A.
Thank you so much, Dr. Barnes. Thank you for all the presentations. So just to start us off, I've been looking at the questions coming into Q&A. So I'm going to just throw a couple of them out there, just in no particular order, and ask my colleagues to jump in. One of them I would come, I think, to you, Dr. Holder, first, of course, and it's about the wristbands. A couple of people have asked about the number that have been sent on for analysis versus the total. So if you want to say something about that.
Sure, happy to. Thank you for the questions. So yes, we have received a total of 4,014 wristbands. As it was a pilot study, we had the funds to initially look into the chemical compounds and exposures collected on 816 of those wristbands. So as we are able to obtain more funding, the goal is to have all 4,014 wristbands analyzed, and that'll allow us to do robust research. But as a pilot study, we're starting with our initial 816.
Great, thank you. And then one more before I switch from you. And it was about some of the exposures. And one in particular was, picking up workplace exposures.
Yeah, so the wristband is able to pick up different chemical exposures in your air as well as in your environment. So whether that be at work or if you go to the gym, in your home environment. So some of those, compounds could be like different. The class is called polycyclic aromatic hydrocarbons, which is a bit of a mouthful. But like that's, for example, commonly found in car exhaust, wood smoke. Other types of polychlorinated compounds can be found in building materials. So maybe that would be something that would be picked up on at work if you're working in a specific building, or in soil contaminants due to improper disposal. So there are different chemical compounds that can be picked up by the wristband no matter where you are while you were wearing it.
Thank you. Then to Dr. Bertrand, around some of the hair relaxer studies, just some, whether there has been anything around like hair toxins from braids or other dermatological issues associated with hair relaxer use.
Yeah, that's a great question. And of course, it's been in the news recently because I think the US Consumer Products report came out and showed that some of these toxins, especially the endocrine disruptors like phthalates and parabens, have been detected in synthetic braids that people are purchasing. And we have not yet collected data on type of braids people use. We've asked people about hairstyles in the past. And so I think that is really something important that we should start to think about including. The data that I'm aware of also come from the Silent Spring Institute, suggesting again that just sort of these off-the-shelf environmental toxicology studies show that the presence of these chemicals in hair extensions and braids. What we don't know yet is, even though those chemicals are there in the braids and there's a potential that people could be exposed, like maybe through inhalation, I'm not aware of any literature that has actually linked exposure or use of braids and these other hair extension products to increased risk of disease. So we haven't quite made that epidemiologic connection yet to disease risk. And I think that's something that absolutely needs to be done, because we do know from other studies that these chemicals, when people are exposed to in high quantities, can affect health, but we just don't know that yet for braids specifically or synthetic hair products.
Thank you. For Dr. Barnes, one question. Well, first, there was someone shouting you out from Chicago, right? And also, are you still accepting women for the dementia study? Oops, you're muted, Dr. Barnes.
Great question. No, we aren't accepting anymore. We reached our baseline enrollment. The goal was 2,500, and we actually have about a little bit over 2,500. But hopefully, we will be refunded when the study is done to look at, more indicators of cognitive function. So stay tuned.
Okay. So another question, and we can all weigh in, but one was, how are participants selected to participate in the wristband in cognitive studies, and also in a similar vein for any of the sub-studies. And I can just start in general in saying that there were some studies where really everyone was able to participate. So when we were collecting, mouthwash samples, we pretty much sent it to everyone. We invited a number of women for blood study. With that, there were some age restrictions. We were looking for, slightly older women to begin with that study. Others are dependent on a particular condition that we might be looking for, a particular exposure, for example. And so it can vary quite a bit, but there usually is some thought that goes into how we proceed. I will, for the wristband and the dementia studies, anything about.
Yeah. For the cognitive health study, it was very similar. We needed older women, so uh, we looked at participants who were at least 55 years of age because you don't really start seeing changes in your cognition until you get older. And also, you had to have donated blood because we were going to be measuring um, biomarkers in the blood and also genetics. So people who had donated blood for another sub-study, they were eligible.
Okay.
And for the wristband project, for our criteria, some of it included, we were interested in getting a broad span of the United States. So we tried to spread out the 4,000 wristbands across the US, as well as women, as Dr. Barnes said, it was part of the blood sub-studies that we can do some cross collaboration with some of our sub-studies. So that was included some of the criteria.
Thank you. Another question for you, Dr. Bertrand, was regarding breast density. I know that this is an area that you have studied. Would you like to say something about that?
Sure, thank you. Yes, so we one of the very first research projects I worked on here at the Black Women's Health Study was a study of breast density and breast cancer risk in the Black Women's Health Study. And many of you may have even participated in that and not even really remember it, but we tried to collect screening mammograms from participants in the Black Women's Health Study. I think we invited like 300, sorry, why am I saying 300? 30,000, nearly 30,000 women who were of mammography screening age at the time, and who had had a screening mammogram after 2008, which is when most of them in the United States became digital. We just wanted to work with the digital data. There's really very few film mammograms happening nowadays. So there were data from white women that suggested actually pretty robust, not just suggested, but it's actually higher breast density, which represents the proportion of your breast tissue that is epithelial or stromal tissue versus fat or adipose tissue. It's a really well established risk factor for future breast cancer risk in many, many populations, white women, Hispanic women, Asian women. And yet there hadn't been many studies in Black women to corroborate those associations. And as many of you know, you're starting to get notifications from your radiologist and your doctor that when you have a mammogram, you're told whether or not you have dense breasts or not. And dense breasts are not, it's not a disease at all. It's just a phenotype. About 50% of premenopausal women have dense breasts. So it doesn't necessarily, even though it's a strong risk factor for breast cancer, it doesn't mean, you're doomed to get breast cancer, but it is something that needs to be discussed in consultation with your provider. So when we collected these mammograms from about 10,000 women in the Black Women's Health Study who had, we were able to find their mammograms. We were able to measure breast density on those mammograms. And we did see, we replicated the findings from white women and saw a significant increased risk of breast cancer for those who had the most dense breasts. So those findings have been published. I'm happy to share the publication if you're interested. But yeah, it's something that needs to be talked about with your provider because it may mean, depending on what other risk factors you have for breast cancer, it may mean that you're recommended to get supplemental screening beyond just mammograms every year.
Okay, thank you. I want to switch to a topic that is on everyone's mind, and that is certainly the current federal environment and about funding and going forward. And so I'll start just by saying that next year is when the study is up for renewal. Obtaining follow-up funding is never easy in the best of circumstances, but we plan to resubmit and put forward a great application to continue funding this research going forward. It's been a tough year for a lot of our colleagues out there, but it's also, we have continued to thrive with this study. So as far as we're concerned, we plan to continue doing our best. Would anyone else like to, did I miss anything? Anyone else want to add?
Maybe I'll just say, like, you know, yeah, it is tough, and it's right to be concerned. Um, we are not stopping this research. We are moving forward in any possible way we can. We think this research is critical, important, and relevant. And you know, there may be like a little bit of a blip in federal funding. There are other sources of funding that we are aiming for, like foundations, although obviously NIH has, you know, is the largest funder of biomedical research in the United States. So I think there's hope and there's optimism. But, you know, being aware, I think people are not, you know, don't really realize how much it costs to do this type of research. So, you know, any advocacy that you can make to your local representatives, I think is helpful. But we're not planning to stop anytime soon.
Yes. And so that also answers one of the questions that we were asked before. Does this study have an end date? Not as far as we're concerned, right? As long as you're willing to be part of it, we're willing to keep it rolling. I think just in the interest of time, because I know some of you will have to drop off, I'm going to just move us forward in our presentation, and to let people know that we will try to address as many of the questions that you've asked. You know, perhaps we'll post them online. Also, this is being recorded, so we will post the video once it's available. But moving forward, I just wanted to, one of the questions again is, what about the next generation? So perhaps the Black Women's Health Study, we are continuing with our cohort. And as I said, we are the women who are currently, you know, ages 52 to 100. That cohort will continue. One of our colleagues, Dr. Lauren McCullough, who is also a member of our external advisory board, is a co-leader of the Voices for Black Women through the American Cancer Society. This study has a goal of enrolling younger women, so women who are between the ages of 25 and 55. So if you have an interested daughter, cousin, friend, sister, granddaughter, this would be an opportunity for them to be involved in research. And this research, although it's not affiliated with our study directly, it's not affiliated with Boston University, where we are located, it does share the goal and commitment of exploring and examining Black women's health. And so we have the website here. You can also Google this, but I would encourage you that this would be really something, an opportunity for the next generation. Also, as we are coming to a close, I want to acknowledge Dr. Lynn Rosenberg. She was the founding Black Women's Health Study investigator, and she is going for a well-deserved retirement at the end of this month. Dr. Rosenberg was in the first cohort of non-physicians to receive a doctorate in epidemiology from Harvard University. And within that class, she was one of only 3 women who went on to do amazing things. Since then, her research has been in the areas of cancer epidemiology, cardiovascular epidemiology, and drug or medication epidemiology, with an emphasis on women's health, particularly that of African-American women. She's carried out multiple studies for risk factors for cancers, including cancer of the breast, cervix, and colon, and for heart disease. She is the founding PI of the Black Women's Health Study, which you know quite well. And certainly during her over 49 years as a member of the faculty at Boston University, she has amassed 523 peer-reviewed publications, and her work has been cited nearly 33,000 times. I speak for myself and perhaps my colleagues as well, but she has been a mentor, a mother, and a friend to many of us on this study and beyond. And I know that we'll continue to see her, but she goes to a well-deserved retirement, and we thank her for her tenacity and pushing this very important research forward that we are all part of now. Just some housekeeping as we get ready to close. Please stay in touch. If you've moved recently, let us know your current address, update your address, your email, if email is the best way to get in touch with you, phone number, etc. We will be sending the 2026 questionnaire by mail at the end of the summer. It will also be available next month by online. So having an email address would be helpful if you would like to receive and complete the questionnaire that way. If possible, add us to your contacts list for your telephone so that we can be recognized on caller ID. Otherwise, we show up as Boston University School of Medicine or 617 area code, which you may not want to pick up. And also, when we give follow-up phone calls, sometimes you call us and we have to call you back. Just make sure that your voicemail box will accommodate our incoming call. At the bottom, the different ways to contact us by telephone, email, on our website, and even on Facebook. With that, I want to thank you, participants, for all that you have done. You really are, you are leaving an incredible legacy for your daughters, your granddaughters, for Black women everywhere. And none of the results that we find would be possible without you. And so before you go, I want to turn this over to our behind the scenes staff, and I want to give them a shout out as well. There are a number of BWHS staff. I won't get all their names, but I want to shout out Delia Russell, Renee Pittman-Williams, Maria Petzold, Carolyn Conti, and the many others that keep this study running. And some of our participants, our staff have a little gift for you, a visual gift. So I'm going to turn this over to the crew behind all of this. 1 second.